Session experts Dr. Abraham Koshi and Dr. Ravi Mohanka. Let's dive into a dynamic and thought-provoking case snippet-based panel discussion. ACLF 2 and 3 now out of the ICU, which will be moderated by Dr. Amit Gupte and Dr. Ashok Chaudhary. Dr. Gupte is a consultant of hepatology at Sir H.N. Reliance Foundation Hospital, Mumbai, where Dr. Chaudhary is an additional professor of hepatology and liver transplant at ILBS, New Delhi. I would also like to introduce our distinguished panelists, Dr. N. Murugan, Dr. Rajendra Reddy, Dr. Suvik Mitra, Dr. Ashisha Janila, and Dr. L. Venkata Krishnan.
Can I have the slides, please, on the screen? So we have a case-based discussion on ACLF 2 and 3 who are now out of ICU. So we'll have two cases which I will quickly present, and then it will be followed by questions and discussions. So case 1, so he's a 64-year-old male, hypertensive, hepatitis B positive detected in 1994, not on any antivirals. In March 2024, he presented with jaundice and weakness. There was no other decompensation. Was evaluated somewhere else, advised to do HBV DNA, but not done at that time. His bilirubin was 18 with the enzymes of around in 2000s. INR was 1.3, creatinine was 0.9. In April 24, that is roughly a month later, he presented to us with grade 2 hepatic encephalopathy, jaundice, and ascites. So he was diagnosed as ACLF due to HBV flare. His MELD sodium at that time was 37, CTP 11C. ARC score was 12, APASL ACLF grade 3, CLIF C organ failure score 11, CLIF C ACLF score 59, EASL ACLF grade 2, and it was type A3 ACLF as per the newly proposed definition. Bilirubin of 38, INR of 2.2, creatinine of 2.2. He was treated with antibiotics and terlipressin. There was no infection. HBV DNA was 6 log. He was started on tenofovir alfenamide. Counsel for liver transplant. Day 2 of admission, he was shifted to ICU in view of worsening of HE. He underwent 3 cycles of plasma exchange, 2.5 liters each on alternate days. And after about 7 days, he improved and was shifted back to wards. On day 8, his MELD was 30, CTP 10, APASL ACLF grade 2, EASL ACLF grade 3. On day 12, creatinine normalized, and on day 14, he was discharged on diuretics. His bilirubin hovered around 20 to 25, INR was around 1.8 to 2.3, and he was worked up for a liver transplant. Now case 2 is a 45-year-old male, diabetes. He was already decompensated AIH-related cirrhosis with hepatic encephalopathy and ascites. He had multiple admissions in the past for decompensations. His MELD was 17, CTP was 7, and was listed for a transplant. In December 2024, he presented with SBP, sepsis, and septic shock, and admitted to ICU. MELD sodium at that time was 30, CTP 12, EASL ACLF grade 2, and it was type B2 ACLF as per the new definition, but he was not fitting into APASL ACLF definition because he was previously decompensated. He was treated with antibiotics and vasopressors. He grew Klebsiella in the ascitic fluid. He improved and later shifted to ward and was counseled for an LDLT. So on day 7, his MELD was 27, CTP was 9, EASL ACLF grade became 0, and he was discharged on day 12 on albumin and midodrine and diuretics. And he was waitlisted for DDLT. So my first question would be to Dr. Ashisha. Will you do an urgent liver transplant for case 1?
Just to summarize, so this is a patient with acute hepatitis B flare. As we saw, he came in grade 3 ACLF with HE, AKI, and coagulopathy. He was given plasma exchange and started on antivirals, with which there was some improvement. Grade of ACLF improved. However, having said that, ACLF has a high short-term mortality of around 30 to 50%, while liver transplantation would give a survival benefit of around 80 to 90%. So yes, as a definitive therapy, I would consider an early liver transplantation for this patient.
Okay. Now, question number 2 to Dr. Souvik. In case 2, would you consider a urgent liver transplant?
Again, considering case 2, we can see the precipitating factor might be sepsis with obvious source of sepsis in form of bacterial peritonitis. So rather than opting for urgent liver transplant, I would like to optimize the patient first with antibiotic. Also, the patient initially was on dual inotropic support. So rather than going for urgent liver transplant, let's put the patient on antibiotics, let's optimize the patient, let's gradually taper down whether the patient is responding to vasopressors or not, and then we can opt for a transplant.
Okay. So we got the opinion that case 1, we would do an urgent transplant, case 2, optimize further and then decide. So I'll give a follow-up of what happened to the 2 cases. So case 1 was listed for DDLT. We counseled him for LDLT. Brother was an option but had fatty liver, so he was advised weight loss and then reassessment. Patient was on close OPD follow-up. TAF was continued, diuretics, albumin, everything was continued. This patient gradually improved, and now he has completed almost 9 months of follow-up, waiting on the waiting list with no LDLT option, but his MEL sodium is now 14 and CTP 7B. Case 2 was waitlisted for DDLT. Sister was a potential donor. However, the remnant was inadequate and hence declined, was on close OPD follow-up. After 6 weeks, he was readmitted with HRS, HE, and patient succumbed in second admission due to progressive liver failure. So, I would like to ask Dr. Murugan, is ACLF 2 or 3 reversible? And what are the factors that predict short-term transplant-free survival in these patients?
Thank you. I think you have demonstrated in your cases that it is reversible. Many times ACLF 2, 3 can improve to 1 or even further. 2, 3 points I want to make. One is that the best time to assess prognosis is day 4 to 7. I think all the guidelines agree on that, rather than on admission. Of course, you do a grading on admission, but if you have a dynamic score, so you reassess at day 4 to 7 after some supportive therapy and see where you stand. The scores coming down is a good prognostic sign, like in your case. Secondly, MELD. If MELD is coming down below 28, that may suggest early transplant-free survival, say 28 or 90 days. Sometimes etiology will give a clue. There are well-documented studies in hepatitis B that if you get a 2 DNA reduction at 2 weeks, the prognosis is better. And in Asia, Hep B is a large part of ACLF. Clinical improvement also, like HE, coming off ventilator, organ failures improving. So these are some of the signs that will do well short term. But your case is demonstrated nicely. I think the first patient was more sick, but he lived longer. Second patient seemed to be getting better, but succumbed. So that is the unpredictability of ACLF. So wherever there is a window, I think you should jump in and do a transplant, especially in an LDLT scenario.
Thank you, sir. Dr. Venkatakrishnan, what are the factors that predict long-term survival in those who survive from ACLF?
Once somebody recovers from ACLF, is out of ICU, I think apart from looking at the short-term mortality, if you look at the long-term transplant-free survival at 90 days and 9 months and 1 year, probably if you are in ACLF 2, it will be around 0.6, and if your ACLF 3 is 0.5. They looked at many parameters which could predict it. One is the male and the age. If you are, especially in ALK hepatitis, if you are younger, probably you expect lesser fibrosis and you may have a better post-transplant-free survival. Then MELD at the onset, especially at the time of admission, it's lower, then they had a better transplant survival. Apart from it, they also looked at if the patient has had an acute decompensation earlier, then his long-term survival is much lesser than if he has not had a decompensation. And the fourth thing is, as in the second patient, they also looked at the comorbidities. It is not the question of the liver disease alone, but the other comorbidity, associated comorbidity may determine your survival, transplant-free survival in these patients. The ACLF grade at that point of admission did not really determine the long-term survival of transplant-free survival in these patients. So it was age, gender, and MELD, which is probably. They also looked at the albumin, presence of hyponatremia, the two other features they looked at, and the WBC count. So they looked at these, but they were not very, they did not correlate with the long-term survival in these patients. And in one Chinese cohort, in the hepatitis B flares and the ACLF, they looked at the CLIF-C score, and lower this CLIF score showed had a better transplant-free survival in these patients. Probably these are the factors which really determined the transplant-free survival in these patients up to 1 year. They have not shown beyond a year what is the status of survival.
Yes, so there are two studies till now which are there in prominently. There is the Dutch cohort, which had primary outcome was 1 year transplant-free survival after discharge in ACLF patients. And what they found, as sir rightly said, age, whether they had any comorbidities, and MELD score at the onset were the predictors of long-term outcome in the survival. And if you can see, the ACLF grade did not predict the long-term survival after they have recovered from ACLF. There's a similar study on in the Korean ACLF cohort, where they saw acute decompensation, whether patient had any acute decompensation in the past was a very strong predictor of the long-term outcome. And even then, when the acute decompensation has happened in context of ACLF, if it has happened within 1 year of ACLF, then versus whether it has happened more than 1 year before ACLF, then that affects the long-term outcome.
Yeah. So thanks. So this is what is long-term outcomes. So now two things we got from the study. One is hepatic reserve, because the first one is the index episode, predominantly liver failure, and hence recovered and long-term is better. The second case, the autoimmune case, is a long-term history of cirrhosis. He has decompensations. Being the same score, she succumbed to the illness. So when you gone through the data long term, so this is the various parameters for etiology wise, how they develop reversal of ACLF, then they progress to develop recompensation, then a regression of the fibrosis. So you can see we have done for the alcohol, these are the various parameters you can see here, Hep C, Hep B, and our case is like this, Hep B. So it is, as rightly said, the 42 weeks one is the factor that provides long-term recompensation this group of patients. And then this is the group of the patients for the who are having all irrespective of the etiologies. And if these people are developing decompensation, getting recompensated, it all depends upon the various clinical parameters we discussed. So these are the few parameters, it is composite and different time points, so that how can go for. As we are discussing how to go for, so this is the Kyoto consensus we have published recently. Here the suggestion is the similar way, the R score or MELD. I think everyone agree that this patient MELD 30 needs to be considered for the transplant definitely. And in that condition, you see how these people are behaving the first week. The first week is major determinant for the short-term outcome to go for these peoples. And I think now we'll go for the concluding remark from Professor Reddy. Yeah, please hear.
Yeah, thanks. So I'm going to quickly make some comments. Wait a second. Okay, good. Is it up here? So, first of all, from my perspective, ACLF is interesting. The organ failures, But from my perspective, the type of organ failure is really most important. You know, if someone had renal failure, acute, they'll do all right with transplant. On the other hand, if they have pulmonary failure, respiratory failure on a ventilator, trust me, it is not going to be easy to have a good outcome. So that's the way I look at it. I look at it as an organ failure issue rather than ACLF grade 2 or 3. And secondly, the other important one is the futility score. Frailty is associated with poor outcomes, which are not part of these various scores. So having said that, I want to make a few points, okay? Can you put it on? How do I do this? Oh, incidentally, the first case, if I'm not mistaken, was not acute B. It's a reactivation of B because the patient had a previous history of hepatitis B. So that's important because if you have reactivation, they could have underlying chronic liver disease. And I must admit, I didn't think that the patient would recompensate because I thought he was too far gone. But I'm glad there was an opportunity to wait and see. Okay, so how do I do it?
Can we have Sir's slides, please? Or you can start the old presentation. The slides are in that. Yeah.
Okay, good. No, anyway. Okay, good. All right. So it's a bit of a balance, liver transplantation in this critically ill patient cirrhosis. You're not sure when to transplant, when not to transplant, but I think we need to look at the data carefully. Now, there are any number of scoring systems, etc., that have been put out in the literature in terms of predicting poor outcomes following liver transplant ACLF. People have talked about organ failures, sepsis, respiratory failure. There are preoperative factors, operative factors, and donor-related. So it's obviously challenging to try and figure out which one to use. So point I want to make is that if you transplant someone in the ICU, you can see the 1-year mortality is around 24%. Transplant them from home or a hospitalized patients, their mortality is lower. 24% is pretty high. If we were to just transplant patients in the ICU and had that common outcome, our program would be rather scrutinized and it could be dinged. So here, you look at post-transplant patient survival with mechanical ventilation. Clearly, those who are mechanically ventilated and transplanted do suboptimally. And on the other side, it's by various grades of ACF. So the message here is ventilated patients transplanted don't do well. Here, looking at futility score, and there are various components of futility score, ventilator support, age, more than 60, hemodialysis, diabetes, etc., their post-transplant survival is poor. Circulatory failure also impacts on post-transplant survival. So both these patients, both these patients were not on ventilator support. The second patient was transiently on circulatory pressor support, and both eventually got better, and both would have been ideal candidates for liver transplantation. And then here, if you look at ICU length of stay, with and without ACLF, independent of donor risk index, with increasing grades of ACLF, there's longer ICU length of stay, longer hospital length of stay. So it's not all about survival. You got to look at some of the other aspects which are of cost. And here, if you were to look at post-liver transplant complications, ACLF, with increasing grade of ACLF, there are more and more complications, apart from longer ICU stay and hospital stay. And then the cost. This has been nicely demonstrated. With increasing grades of ACLF, the costs go up significantly, and that's another factor that you need to take into account. And then apart from that, with increasing grades of ACLF, there's a greater rate of acute cellular rejection, bacterial infection, and dialysis dependence. So there are other aspects apart from just survival that you need to take into account. And futility of liver transplant ACLF, organ failures, is a predictor of futility. Respiratory failure, talked about mechanical ventilation, high vasopressor support, and frailty score and a futility score are important. So you need to take all of this into account prior to deciding on a candidacy. My feeling is the best thing is the eyeball test. You can have any number of poor prognostic factors, etc. After 3 or 4 decades of being in transplant field, I can tell this patient is likely to do well and this patient is not likely to do well. So so that's about it. So we could certainly have a discussion if there is time. Thank you so much.
Thank you, sir. Thank you, everyone. I would like to thank our chairpersons and moderators also for this enriching and insightful session. I would like to now welcome the chairpersons for the next session, Dr. V.K. Dikshit, Dr. Siva Prasad, A.V., Dr. B.V. Tantri, Dr. Tanmay Vajpayee, and Dr. Mayank Kabrawala. I request the chairpersons to please introduce the speakers.
Good morning to this important session where we have 2 important talks by legends. Now, first talk is by Dr. Patrick Kamath. He doesn't need any introduction to this audience. And he's going to tell about how we can improve the survivals in the end-stage liver disease. Dr. Patrick Kamath.
Thank you so much, Vinod. So let's take a case scenario, a little different from the previous ones. So this is a patient with alcohol-related liver disease. In the ICU, jaundice, ascites confused, bilirubin 17, AST greater than ALT, MEL 36, driven predominantly by prothrombin time, and creatinine 1.8. So this patient fortunately responds to steroids and stops use of alcohol. So then the MEL score drops to 22, and he is listed for liver transplantation. So the question is, how do you keep alive this patient who is at high risk for mortality? So for that, we have to go back to how the hepatocyte gets injured. The normal hepatocyte takes up ammonia and releases urea into the circulation. The hepatocyte also divides into daughter cells, and that is mitosis. When the hepatocyte is injured, the hepatocyte dies so that ammonia cannot be taken up, and ammonia and other waste products then get into the circulation. Dead cells attract inflammatory cells from the extracellular matrix. So inflammatory cells release inflammatory cytokines. These are pro-inflammatory. So then there's inflammation in the systemic circulation. And inflammation, predominantly histones, inhibits mitosis. So the end product of any hepatocyte injury is waste accumulation, systemic inflammation, and impaired regeneration. So if you have to try and keep the patient alive, you have to try and target all of these. In the limited time left, cannot go over these in detail, but we'll just go over a few important features here. So let's take this patient again with alcohol-related liver disease. What are our therapeutic targets? Patient had compensated liver disease. The alcohol use resulted in alcohol-associated hepatitis, of whom about 2/3 or 3/4 will have underlying cirrhosis. Patient gets infected. So that if you have to keep these patients alive, you have to treat the alcohol-related hepatitis, you have to treat infection. If the organ fails, then they need organ support, and if all that fails, you have liver transplant. But if that succeeds, then you can get them back into compensated liver disease. So these are the broad principles of treatment. So these are our goals. We want to improve quality of life in these patients. We want to stop alcohol use in alcohol-related hepatitis, as you saw in the previous patient. If this patient had hepatitis B, we would treat the hepatitis B. You have to treat infection, and we'll go over how you treat them. They are at risk for infection. If organs are failing, we have to support the failing organs. And is there a role for liver regenerative or bioartificial therapies? And if all that fails, that's when we consider liver transplantation. I think improving quality of life in these patients is extremely important, whatever time they have left, even if they're not candidates for liver transplantation. So there are multiple factors which result in impaired quality of life. I won't go over them in detail because I know there's a separate session on that, but hepatic encephalopathy needs treatment, ascites. If they bleed, there's the fear of rebleeding, itching, fatigue and depression. Think of all these things that require treatment. Pain is an issue, cramps, sleep, sexual dysfunction. There are many other features. Do not forget nutrition in these patients. They require nutrition. As Raj told you, they have got sarcopenia. So these are patients who require physical and occupational therapy. So it's not only keeping them alive, it's keeping them in a better position so that they can function or go to liver transplant. So nutrition, sarcopenia, some exercises, try and work on that. Keep them mentally active, physically active. Then stop alcohol use. This patient has alcohol-related hepatitis, really important. So we have Alex Louvet's study showing you really well what the importance of alcohol cessation is. So patients with severe alcohol-related hepatitis, severity at baseline and response to treatment at day 7 with the Lille score, that will determine whether they are alive at 6 months. If these patients do not relapse to alcohol, they've responded to treatment, they will be alive for a long time. They have a minimal risk of death. On the other hand, if they've not gone back to alcohol, but they've not responded initially to treatment, they have a substantial risk of death. So these patients consider for liver transplantation. The problem is those with alcohol relapse, they have a high risk of death. So in them, consider palliative care. So in the short term, how do you want to keep them alive? In the short term, target liver injury. Right now, we only have steroids. For the longer term, target alcohol behavior. There are different interventions, and there are also pharmacological treatments, which you might consider. They're still considered investigational, though. These patients are prone to infection. So how do you treat infection? This is a little bit of a busy slide, and I hope you can see it well. So when we see a patient with infection, mean arterial pressure less than 65, saturation 90, heart rate less than 40 or greater than 130, respiratory rate less than 10, greater than 28, or persistent decrease in level of consciousness. For us, this is an indication to move them to the ICU. In the ICU, I'll go over briefly what we do, but in the next slide, I'll go over in more details. We would investigate them for infections. We would treat infection with vancomycin meropenem. There are general measures. We want enteral nutrition, which we preferred. We want fluid resuscitation, paracentesis, aspiration precautions, DVT prophylaxis, stress ulcer prophylaxis. Mean arterial pressure is still less than 60. That's when we would consider norepinephrine. And if it persists less than 60, that's when we consider hydrocortisone. I'll go over this in a little more detail in the next slide. More important is if they don't have an indication to transfer to the ICU. What are the investigations we'll do? Paracentesis, blood acidic fluid and urine cultures, a chest x-ray, and if they have diarrhea, we'll do stool for C. difficile. Acidic fluid more than 250 neutrophils, that's SPP, cefotaxime, albumin. We will repeat paracentesis at 48 hours. If they've got pulmonary infiltrates and respiratory symptoms, that's a pneumonia. If they've got urinary symptoms, just white cells in the urine is not enough. They've got urinary symptoms and positive gram stain or culture, that's urinary infection. The antibiotics, you have to decide which one of them is important, because there's a different treatment for community acquired, for healthcare associated, and for nosocomial infections. When they have an infection, response is typically clinical. You want their lungs to look better and feel better, and the urinary symptoms to go away. If they've got diarrhea and C. difficile is positive, that's C. diff infection, we'll use vancomycin. And again, the response is symptom resolution. You don't need to check C. diff again. Positive blood cultures, that's bloodstream infections, piperacillin tazobactam, and the endpoint is negative cultures. So this is if things are going well. But sometimes things don't go well. So if there's no resolution or condition worsens, you have to bring the family together. So we have a meeting with the family and you have to take decisions. Either we say, okay, this is futility, we'll consider end-of-life care, or we may decide to move to the intensive care unit. In the intensive care unit, as I said before, cultures, treat infection, broad spectrum antibiotics, you pick whatever is best for you. No response in 48 hours, consider antifungal treatment. General measures, point of care ultrasound for fluid resuscitation, paracentesis, aspiration precautions, DVT prophylaxis, and stress ulcer prophylaxis. Consider norepinephrine. No response is probably adrenal insufficiency. Consider hydrocortisone. And also these organs are failing. So what do you do here? So this is from Jules Wenden and Will Bernal's paper. They have a systemic inflammatory response like I showed you in the initial slide, which results in brain, cardiac, lung, worsening of liver failure. They get intensely cholestatic. Adrenal insufficiency, that's why we consider steroids. Acute kidney injury, they get immunosuppression, and they are prone to a second infection. So in the failing organs, let's just talk about acute kidney injury. Creatinine increases greater than 0.3 but less than twofold, that is stage 1A, if the creatinine is less than 1.5. In these patients, withdraw nephrotoxic drugs, diuretics, treat infections, volume expansion. If they resolve, you can monitor. But if they don't resolve, that's when you consider albumin 1 gram for 2 days, 1 gram per kilogram. On the other hand, if the creatinine is greater than 1.5, you will start off right away with an albumin 1 gram for 2 days. If they resolve, you will monitor. If they don't resolve, you check the urine, do whatever test that you want. If it's consistent with ATN, consider renal replacement treatment. If it's consistent with hepatorenal syndrome, vasoconstrictor therapy and albumin. Sometimes you're not quite sure what the diagnosis is. In that case, we would consider vasoconstrictor therapy and albumin, and on a case-by-case basis, we would also consider renal replacement treatment. So in general, the decision for renal replacement treatment will depend on what the cause of the acute kidney injury is and whether they're candidates for transplant or not. So ATN transplant candidate, for sure we will dialyze until transplant, and these are candidates for potential liver kidney transplant. If they're not transplant candidates, we will dialyze them, but it's more limited trial. HRS, AKI, transplant candidate, yes, we will dialyze. Not a transplant candidate, we'll be very selective. Typically, alcohol-related hepatitis, we may consider dialysis in these patients. But often we don't know. Again, depends on whether they're a transplant candidate or not a transplant candidate. And it's a limited trial of dialysis. So in general, the decision about renal replacement treatment requires discussion, and it depends on the etiology of AKI and whether they're candidates for transplant or not. Finally, What about regenerative treatments? GCSF, I know there's going to be a talk later. The meta-analysis, 7 studies for alcohol-associated hepatitis, favorable effect in Asian studies, not outside. So the use of GCSF requires validation outside of Asia. Liver support systems, Jules Rendon went over this yesterday. Heterogeneous groups have been studied, but largely alcohol-associated hepatitis. Limited randomized studies. 16 trials have been used with different devices. Essentially, the role for liver support systems has not been clearly demonstrated. If anything, PLEX may work a little. It has the most promise. So my take-home messages: patients with cirrhosis are at high risk of dying. I generally give them the 50% rule, 50% chance of dying in hospital and 50% chance of being readmitted in 6 months. Aggressive and early intervention is required. So reverse alcohol-associated hepatitis. If it's hepatitis B, treat hepatitis B, treat infection, support failing organs, and remember, treat alcohol behavior. Benefit of liver support devices has not been demonstrated, and in selected patients, consider liver transplantation. Thank you.
Thank you, Dr. Patrick, for that wonderful discussion on critically ill cirrhotic. We move on to the second talk, that is gut microbiome report to prognosticate liver diseases, when to ask for and how to interpret. Dr. Kiite, please.
Thank you for your introduction. I would like to talk about the gut microbiome report to prognostic liver disease. So I will present by this order: microbiome in liver disease, microbial precision medicine in liver disease, and the conclusion. So I will give the 3 questions. So what would be the potential role of the microbiome and the microbial metabolite in liver disease? Second, could specific microbiome patterns be prognostic markers of liver disease? Third, when to ask for and how to interpret it. As you know, liver disease is a clinical spectrum of disease, consists of fatty liver, hepatitis, liver cirrhosis, and hepatocellular carcinoma. Most common causes are virus, alcohol, fatty change, and microbiota. In case of hepatitis, 7% of patients shows the mortality rate during 15-year follow-up. Regarding liver cirrhosis, 5-year survival rates are very low. So 1/3 of Korean adults are classified as having MASLD and related SLD. Now, regarding alcohol liver disease, 49 countries shows an increasing prevalence rate of alcohol liver disease in the past 2 decades. So microbiome is a community of microorganisms. It consists of the bacteria, microbiome, and the virus. So alcohol liver disease and MASLD are closely related to the gut microbiota. We can call it the gut-liver axis. Gut microbiota plays an important role in a wide range of liver disease. Microbial biomarkers might also provide new insight into disease pathogenesis, perhaps leading to novel therapeutic approaches. As a diagnostic markers, metagenomic signatures hold a potential as diagnosis for the decompensation. As a prognostic marker, microbiome-based biomarkers identify patients at high risk of the ACLF in patients with liver cirrhosis. As a predictive biomarker, microbiome signatures identify patients with decompensated cirrhosis who are most likely benefit from therapy. As a monitoring biomarker, the monitoring effect of the microbiome-based therapy can be used. So I will talk about the cirrhosis. So median time to decompensation from the cirrhosis takes 10 years. And the median time to ACLF from the decompensation takes 2 or 3 years. Patients need the frequent hospitalization. Median time to death from the ACLF is 2 months. They need ICU care, the mortality rate of 40%. So if I say the publication history, so about the cirrhosis and the dysbiosis. So firstly, so ileum of the patient with cirrhosis harbors an excess of Colicum bacteria. This is publicated in 1957. After that publication, the Dr. Bajaj mostly, so their group published the main paper about the cirrhosis and dysbiosis. We can use the next generation sequencing and the bioinformatics, so we can know the molecular level of the bacterial species and the cluster metabolic functions encoded by metagenomic species. So if I say the cirrhosis component typical characteristics, so compared with the health control, patient with liver cirrhosis patient had fewer bacteroid deaths and higher level of proteobacteria and fusobacteria. In that paper, they suggest that the Faecalibacterium and Coprococcus are decreased in patients with liver cirrhosis. Faecalibacterium is associated with anti-inflammation. Coprococcus produce the butyrate. So good bacteria is reduced in patients with liver cirrhosis. And bad bacteria, I do not know exactly. However, Bayonella species, Streptococcus, Clostridiums are increased. They are all so related with the poor prognosis. They are related to oral microbiome. It means that they are mislocated in the stool, not oral area. It means that they shows the bacterial overgrowth and the translocation. So in case of the regarding the metabolism, histidine metabolism, ornithine biosynthesis, nitrate metabolism are changed compared with the control group. So ornithine, nitrate, histidine metabolism are related with hepatic encephalopathy. So in another study, 200 patients were studied using quantitative metagenomics. As you can see here, so microbiome correlated with clinical outcomes, survival, and functional changes. So in patients with decompensated cirrhosis patient shows the elevated level of fusobacteria, proteobacteria, enterococcal, streptococcus. In another study, decompensated cirrhosis patient shows the typical finding of microbiota composition. So Bayonella and fusobacteria are increased in decompensated patient. Compensated and decompensated patient shows the significantly different microbiota compositions. So interesting finding is that the metagenomic species are closely associated with the disease severity. As you can see here, in a prospective study, the 182 patient study group, so they shows the altered microbiome was associated with the complications of liver cirrhosis and the complication. In another study, so Bajaj selected compensated patient and then see the long prognosis. Some patients shows the post-decompensation. So that patient shows the higher level of this microbiota composition. Ordinary bacter and the lactobacillus species are increased compared with the other stable patient. In another study, called microbiota is related with the microbiota relating, associating metabolites. In a USA study, Bifidobacterium and the Brautias are related to post-choline and the lactate. A Mexico study shows that the lactobacillus is closely related with the lactate. So through microbiota shows a linkage with the plasma metabolites in a multinational cohort study. In another study, they used the AI and machine learning technique. They shows the higher level of AUR curve in the diagnosis of liver disease and cirrhosis by using the metabolite and microbiome and the clinical finding. In our study, we also used the machine learning study. In our study, we shows the higher level of AURs in the diagnosis of hepatitis, cirrhosis, and liver cancer. Another study, we found that the microbiome are typically increased in the complication, cirrhosis complication. In hepatic encephalopathy, Bayonella dyspa and Streptococcus aureus are increased. In the SBP, E. coli and Helveticus are increased. Microbiota and metabolites can be used as non-invasive biomarkers for the diagnosis of cirrhosis and each complication. In another study, we checked the microbiota composition in two cohort studies. In first study, we checked the hepatic encephalopathy, so has this typical finding of the microbiota. Echinacea mucini pili is significantly decreased in the patient with cirrhosis with hepatic encephalopathy. in another cohort study, at that study, we collected the cognitive function dysfunction patient. So they show the decreased level of acclimation and muciniphila. So in animal study, we can show the acclimation and muciniphila composition levels was decreased in DDG diet animal model. So acclimation and muciniphila can be a prognostic and diagnostic marker in liver fibrosis. Liver cirrhosis and complications of the typical microbiota composition. So upper level of healthy control group shows a typical microbiota level, and the cirrhosis patients shows the typical microbiota level. Complication also have a typical microbiota compositions. So, and the metabolites also are different in patient with the control group and in patient with the cirrhosis group. If the cirrhosis complication is more than one, more than two, the complication related microbiota metabolite is changed. So another group checked the correlation network analysis. They shows the microbiota is related with another microbiota. However, this correlation, the relation is different according to the disease severity and the state. The interesting finding is the virus also related to the microbiota. So microbiota, such as Ruminococcacea and the Lactobacillus, are closely related inflammatory cytokines. It means that the microbiome metabolites are closely related to inflammation, infection. So it means that microbiota was closely related with the ACLF and SIRS. So you can say that the compensated patient in cirrhosis patients closely related to microbiota. In summary, microbiome is also during development of liver cirrhosis, and these changes are associated with the decompensation and the development of ACLF. Progression of liver cirrhosis toward decompensation and CLF is mainly driven by the extent of systemic inflammation. Microbiota can contribute to systemic inflammation. I will say about the MESLD and MET-ALD. In our study, we can see the hepatitis and the healthy control and the patient shows different types of the phylum composition. In previous our study, we can say that the normal control, fatty liver, and the MASH patient has a typical microbiota composition. In MASH patient shows the higher level of E. coli growth level, the bacteria. So we can say carefully, so E. coli can be a bad bacteria in patient with MASH. So in MET-ALD patient model, so the human study, we found that the phylum compositions are significantly different according to disease progression. Alcohol hepatitis and alcohol liver cirrhosis show the decreased level of bacterial deaths. In MET-ALD and ALD patients also different types of microbiota composition according to the disease progression. If the analysis the metabolite of the stool, so MESLD patient and MET-ALD patient shows different types of typical metabolite composition. So we wanted to know the correlation with the microbiota and the metabolite. We analyzed the microbiota and the metabolite result by using the empirical sequencing. In that sequencing, we found that so by using the metabolite and the microbiota, we can easily, efficiently, effectively can diagnose the alcoholic hepatitis MESLD patient. We can summarize our result by this graphic abstract. So microbiota composition are different according to the disease. So between non-alcoholic fatty liver disease, MESLD, and alcoholic liver disease. Metabolite composition also different between MESLD and MET-ALD groups. So in summary, dysregulated microbial metabolites induce liver disease. Microbial metabolites are associated with the severity of the liver disease. Metabolic pathways is different according to the liver disease. Metabolic difference can be used for the diagnosis and the treatment of liver disease. Conclusion, in the liver disease, microbiota and its metabolites play the central role in the disease progression, and the specific microbiome patterns can be prognostic markers of liver disease. Thank you very much.
Thank you. It's now open for questions. Few questions, first from the chairpersons and then the audience. both to Patrick and to Dr. Su.
I have a question for Dr. Patrick.
Patrick, please come up or go to the microphone. Yes.
So my question is, in the situation that you described, is there any potential role for rifaximin in an off-label indication for the prevention of progression of liver disease, apart from the traditional indications?
So the question is, what is the role of rifaximin in such a situation? So people had talked about rifaximin for a long time, and also simvastatin. So this week's JAMA has the paper, the European study of 9 countries. In patients like this, they were given rifaximin and simvastatin. This is double placebo. The ideal study would have been rifaximin alone, simvastatin alone, combination, or nothing. But just because of funding, it was only this. There was no benefit at all. So that's problem number 1. Problem number 2 is there's a paper in Nature which came out in October, it's from Australia, showing that those on rifaximin develop daptomycin resistance. So this creates genes for daptomycin resistance. And you know, daptomycin has some role in tuberculosis, especially in multi-drug resistance. So I think you have to be extremely careful about rifaximin. I'm not saying it's not a good drug. Just be extremely careful, and I would not use it for indications that are uncertain.
Any other questions from the chairpersons? No, it's open to the audience for questions. Yes? You want to ask a question, sir? Oh, speaker, sorry.
Yeah. So for Dr. Sook, so it's pretty clear from your talk that there is increasing ability to differentiate between cirrhosis and various stages and with metabolomics and microbiome data. Now, is there a way, or have you reached that point where you can preempt or sort of know beforehand, before a patient develops a certain complication, that this patient is going to have this?
So I showed the Korean data, and then
Can you predict a complication from the metabolomics?
Yeah. So in my data, so I show the metabolic composition can differentiate.
It's not audible, sorry. It's not audible.
I see. Oh, sorry. Yeah. So metabolic component can be used as the predictive marker for the diagnosis of liver cirrhosis and complications. So typical the metabolites as indole component. Indole 3 propionate is a good guy as a metabolic component. They can be used as modulating the allyl hydrolase receptor, and they can be used as the virus modulation factors. So indole 3 propionate are increased in normal patient, however decreased in the liver cirrhosis patient. And another metabolic component is the tryptophan. And that tryptophan associated other metabolites can be used for proxy markers.
Thank you. Any other questions? No? Thank you.
I have one question for Dr. Raj Reddy. So, one of the things that you said in your slides is that it is, programs in the US are under increasing scrutiny, and with a 24% mortality, let's say if you take up patients with ACLF, it's really difficult because the program itself may shut down. Yeah. So now, do you see that most programs in the US are becoming more risk averse because of this increasing scrutiny, and people are moving away from transplanting ACLF and sort of preferring to just transplant decompensated cirrhosis instead?
Yes, Ravi, it's an important question, and it is happening one way or the other. I'll tell you how. So, cost. The sicker the patient, as I pointed out, the greater the cost. So if you spend a lot of money, and the hospital is seeing that you're losing money rather than making, so you could get pressure from there. Secondly, if your outcomes are poor, you're going to get pressure from UNOS. So one way or the other, it is happening or has happened. And so something we don't transplant patients in the ICU, except for acute liver failure. There are some programs that are transplanting patients in the ICU. And now they're getting stung, because they did a lot of those, and the hospitals are putting pressure. So there's accountability, so something that will sooner or later level the field in terms of patient selection. So now that you have extracorporeal, perfusion, etc., it's kind of the field has reversed in the sense that they're taking more and more compromised organs, perfusing them, and patients with lower MELs are getting transplanted. So it's not like they're all very sick. So that's the way the field is right now in the US. Thank you.
We close the session. Thank you.
Thank you, sir. Thank you to the speakers for this thought-provoking session.